welcome to today's webinar, part of the Ioneer Foundation Sight and Sound webinar series. This bi-weekly webinar series highlights the research taking place at the University of Pittsburgh School of Medicine. My name is Craig Smith. I'm a development officer with the Ioneer Foundation. What we do is we support research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds we provide from the Ioneer Foundation support research are only made possible because of philanthropic support. So thank you to anybody who has been a donor in the past in helping us advance this research in both departments. Just a few housekeeping rules for today. You'll notice the chat is disabled, so you won't be able to chat. However, the Q&A function is open, and please feel free to submit questions throughout the presentation, and our presenters will go ahead and answer those questions at the end of the presentation. We do ask that you refrain from sending very specific or personal medical questions that might not be relevant to the larger audience. But if you'd like to, you can send those to me at craig@ioneer.org, and I'd be happy to pass them along to Dr. Perez and Dr. Williamson to see if they can provide an answer for you. And also, I just want to let you know that everybody that is on today's webinar will be added to our mailing list, and that way you'll continue to get emails from the Ioneer Foundation highlighting our blogs, our newsletters, and webinar invitations for future presentations as well. Excited about today's topic, which is hearing with the brain, and I'm joined by Dr. Philip Perez and Dr. Ross Williamson. Dr. Philip Perez is an assistant professor in the Department of Otolaryngology, specializing in otology and neurotology. A large portion of his clinical practice focuses on hearing rehabilitation with cochlear implantation. Dr. Ross Williamson is an assistant professor of otolaryngology, neurobiology, and bioengineering at the University of Pittsburgh. His research utilizes state-of-the-art experimental and theoretical tools to understand how neural circuits give rise to sensory-guided behavior. So I'd like to turn the presentation over now to Dr. Perez, who will get us started. Dr. Perez.
Thank you so much. Thanks to Craig and Christine and the entire foundation for really spearheading events like this that I think are so exciting and fun to get to share, what is happening in the Department of Otolaryngology and how, generous support from donors and engaged members in the community really contribute to advancing the care, and especially with hearing care. I'm so excited to be talking to you about part of my clinical practice and describe this general topic of hearing with the brain. So today I'd like to talk about a couple of things. I'll give an introduction to cochlear implantation, which is just an incredibly exciting development within the field of otology that's really changed how we treat hearing loss, and really been one of the huge success stories in research leading to real benefit for patients. So it's exciting to introduce that to you and talk about some of the clinical practice that happens here at UPMC. We'll talk a little bit about the development of cochlear implantation and what the current clinical landscape is. And then a topic within that that's always interesting and germane to this discussion of how hearing relates to cognitive function specifically deals with the progression of dementia and research in how hearing rehabilitation can address some of those issues. So what is a cochlear implant? A cochlear implant is an incredible piece of technology that really improves the lives of hundreds of thousands of people worldwide. And it's really one of the reasons that I went into this field, into otology, is just seeing the incredible change that this can bring through a successful surgery and through the plasticity of the brain to adjust to new inputs we provide when hearing system is no longer functioning the way it should. So this is a picture of a cochlear implant, and this is a typical cochlear implant. There are a few different versions, but you can see this woman is wearing the typical behind the ear portion that looks kind of like a large hearing aid. And that encompasses a microphone that's receiving sounds, a battery pack that's powering the device, and transmission to this coil that sits on a magnet behind the head. And that magnet is making contact with a magnet that's part of the device that's surgically implanted underneath the skin to transmit those electric signals that then are sent by electric pulses to the cochlea to directly stimulate the hearing nerve. So here's another diagram shown that includes the external portion that we saw in the last photo, and then shows the internal hardware that we place surgically. That includes an internal receiver that sits underneath the scalp in an area behind the ear. That has an electrode that then is placed into the cochlea. And you can see this electrode array with 22 different contact points that are making contact with the cochlea to directly stimulate nerve endings that then are sent to the intact auditory nerve. So in general, this is the option we start to discuss when hearing loss has become so poor that even the best hearing aids aren't compensating for nerve hearing loss that's occurred. And that's in part because the nerve damage that happens in the cochlea can no longer create usable signals that are sent to the auditory nerve, but in most cases, the auditory nerve is still functional, as well as the upstream circuits that you'll hear more from Dr. Williamson about that lead to all the processing that happens in the brain. So it's just incredibly lucky that this works, that the brain receives these signals and is receptive to a plastic change that takes really just electric pulses and turns them into something that's meaningful hearing. So how did we get to this point? There's a long history of cochlear implantation development, and some of the earliest studies were done in 1957. A patient was implanted by a couple of ear surgeons in Paris. It was a patient who had undergone multiple ear surgeries and had exposure of the hearing nerve, the auditory nerve, on which they placed a single electrode, and they were able to stimulate that electrode and elicit a perception of sounds from the patient, not speech understanding, but ability to perceive, yes, I'm hearing sounds from this device. Just a few weeks later, the device failed and didn't go much further in that research environment. But it was published in the scientific literature and brought to the attention of Bill House, a prominent ear surgeon in Los Angeles, who in 1961 began to implant several patients with a 5-electrode wire. So a wire that was fed into the cochlea, into the inner ear hearing organ to directly stimulate the nerve of hearing. And in those patients, they had sound awareness. They had some perception that, yes, I'm hearing speech. But ultimately, there were issues with infection of the device being rejected by the body that actually led Dr. House to put aside those experiments for several years. And it really started to develop with the biocompatibility of things like ventricular peritoneal shunt in the brain, pacemakers used for the heart, where the technology for implantable devices advanced to the point where patients were able to have these devices long-term without the rejection and infection issues that had been present with earlier experiments. In the 70s in San Francisco, a neurophysiologist and otologist worked together, Dr. Mickelson and Meresnick, to implant several patients with single electrode implants. And what was important about that is it was the first implant that could actually be used outside of the lab. And they also developed a multi-electrode system. So these were not the streamlined devices of today. And I hope that we're saying the same thing in 20 years from now, that we look back at what we have and say, wow, I can't believe we had this big clunky thing sitting outside, but we have come a long way. And so some of these pictures show a relatively similar size of electrode, internal receiver and electrode. But then you see this large external processor that's either worn in a pocket or with a strap that connects to the same system transmitted through the skin and a coil. Other early developments in that electrode show large, bulky devices, smaller number of electrode contacts. So at first that was a single electrode. Today's cochlear implants use 22 electrodes. So really big advances in the technology, but a very similar idea. We're taking sound from the outside, using a processor to turn that into meaningful, repetitive electrical stimuli, and sending those stimuli to the inner ear cochlea to send via the cochlear nerve to the brain. So, early on, as this was being developed, the scientific and the medical community was very skeptical of cochlear implant. This was kind of rogue cowboy, cowgirl research that was not thought to be mainstream or recommended for patients. It was really pretty experimental. And because of that, actually, in 1976, the University of Pittsburgh played a role. The NIH commissioned a study here, led by Dr. Bilger, who basically examined the results of patients who had been implanted in the US over that time period. It was a total of 13 subjects, and really pivoted some of the viewpoints in the medical community to show that quality of life was improved and speech understanding was improved in these patients. So following that timeline, in 1980 is the first year that children were implanted. And then in 1984, the FDA approved the first cochlear implant device, the 3M House cochlear implant that was developed with Dr. House and his colleagues in Los Angeles. So the technology has continued to improve, continued to progress in the ability to enhance patients' ability to understand speech with this device. Increasing number of channels, improvements in the ability to process that sound and process speech signals have really improved patients' ability to understand speech. So today there are 3 companies that have approved devices in the US. Cochlear America's Advanced Bionic and MED-EL all have approved devices and have different iterations of those devices. And what remains somewhat constant is the internal hardware is pretty similar with improvements in the external processor. But we seem to be reaching somewhat of a plateau in terms of the limitations of how many electrodes you can fit in the cochlea and stimulate those nerves along the length of the cochlea, which is organized from low pitches, from high pitches to low pitches tonotopically, that allows you to stimulate a certain region of the cochlea and say, I expect a frequency or pitch in one area, and you can progress along the keyboard to stimulate the inner ear. So as of December 2019, there have been more than 700,000 registered devices worldwide that have been implanted. In the United States, that's almost 120 in adults and 65,000 in children. And here at UPMC, we do about 1 adult cochlear implant surgery a week, and that's done by Dr. Andy McCall and by me. And that's in addition to the large cochlear implant practice at Children's Hospital overseen by Dr. David Chi. We have 3 dedicated cochlear implant audiologists here who work with these patients to help do all the testing before surgery to determine who is a candidate. And we'll talk a little bit about how we get to that decision. And then really do the work of helping patients learn how to hear, how to train the brain once this device is implanted and they begin the process of training the brain how to understand speech once again. So this program continues to expand. We're working on streamlining access to cochlear implantation across Western Pennsylvania and really the entire catchment area to allow patients to show up, have their testing, have the discussion with the cochlear implant surgeon, me or Dr. McCall, and make plans for surgery and patients for whom that's appropriate. And an exciting feature about cochlear implantation is the broadening candidacy. Who is the right person who we think really can benefit from this therapy? And so early on, the people who were candidates for this were adults who are deaf in both ears. But as we have seen improvements in the performance of cochlear implantation users, those indications have broadened. So children are implanted as early as 6 months of age, and they're implanted in both ears. Those children who would have been born deaf have the ability to develop completely normal speech and track with their normal hearing peers throughout normal education. We also now can implant adults who still have some residual hearing. So you can still retain the ability to perceive some pitches, especially if they're lower frequency hearing, but have poor speech understanding. And that's in part because we see with cochlear implantation a very high level of performance that shows us, there are patients who may be getting by with hearing aids, but actually can perform better with a cochlear implant. In 2019, the FDA broadened the indications to include people who are deaf only on one ear, called single-sided deafness or asymmetric hearing. So before, where you'd be in a monaural state, not being able to localize sounds, having difficulty hearing in noise, we now have the option of a cochlear implant to help with some of those issues. So the issues in the progression of cochlear implantation technology and surgical technique include: how can we best preserve whatever hearing is left? So can you have a cochlear implant electrode placed in the inner ear that doesn't destroy all the residual hearing, still leaves some hearing behind, and then hear with both a cochlear implant and with a traditional sound stimulation coming from the same device? Sound localization is improved in the new indication for single-sided deafness. Tinnitus, noises in the ears, for many patients are shown to be suppressed, and that's an active area of research as well, where could a treatment for tinnitus in patients who have poor hearing really be a cochlear implant? And then various programming for music appreciation in cochlear implant users. So the other big way this ties into hearing and the brain relates to hearing loss and cognition. So we have an aging population, we have an increasing prevalence in age-related hearing loss, which is the most common cause of hearing loss that ultimately lends a patient to becoming a candidate for cochlear implantation. So somebody who had relatively normal hearing in their youth and in their older age developed hearing loss. And we know that there are close associations between hearing loss and decreased function in terms of social, emotional, physical, and cognitive capacities. So all these parts of an aging person's ability to continue to live a high quality of life can have an impact with appropriate treatment of hearing loss. And for some patients, that's a hearing aid. And when the hearing loss is so severe that even a hearing aid isn't cutting it, that's when we think about a cochlear implantation. So there's ongoing research in the outcomes of cochlear implantation performed for patients who are in their 70s, 80s, and 90s. And it really does show that these patients benefit similarly to cochlear implantation that's performed in younger patients. And it's important because it's an overall safe surgery, an overall low complication rate from the surgery. And so one that we're increasingly trying to help patients understand if it's the right option for them. So importantly, older adults are happy with their cochlear implants and they use them for a long time. We do see that with an increasing age, there's a decreasing speech recognition score performance. So how much ability to understand speech is going to return can diminish with increasing age, but we still see high performance in many older users of cochlear implants. And a really important study came out in 2017 from the Lancet Commission on Dementia Prevention, Intervention, and Care that showed up to 35% of dementia cases are potentially preventable. And the number one modifiable risk factor for those preventable cases is hearing loss. So it's a huge area of impact from a public health standpoint, starting with hearing aids, but recognizing that for some patients, a cochlear implant will ultimately be the right option for them. And this connection between hearing loss and cognitive function is one that it's easy to understand in terms of a use it or lose it scenario where, hearing loss that will isolate you from your family, isolate your ability to participate in the world around you, engage with loved ones, with your friends and your community, really has a huge impact on your overall health. And so the research that's been done in cognitive function and treatment of hearing loss shows that multiple factors are improved with hearing rehabilitation. And that's not to say that cochlear implantation reverses dementia, but it seems to be able to pause some of the progression and is one area where we really can intervene to address a huge public health issue. So then that becomes the question of when to implant. We've discussed that as we see really excellent performance with cochlear implants, we are broad in how we consider who is a candidate and when is the right time to intervene, where we think we've crossed the line from benefiting from hearing aids to really improved benefit with a cochlear implant that may help stave off future cognitive issues. So next up, you're going to hear more about this pathway of hearing, starting in the ear, but going through the brain, and some of the exciting research that Dr. Williamson is doing that's continuing to advance how we understand the role between hearing and the huge function that the brain plays.
Awesome. Thanks very much for that, Phil. And thank you for coming along and listening to this. And thank you to the Eye and Ear Institute for giving me this opportunity to share this research with you. So I'm going to give a largely biological talk. I'm going to touch on various translational implications as we go through. But really what I want to talk about is how important the brain is for our perception of the sensory environment. So my lab is particularly interested in understanding how we use sounds to interact with the world around us. So sensory stimuli, whether they're sights or sounds, are always typically associated with distinct behavioral outcomes. And this is largely what I mean when I refer to terminology like sensory guided behavior. So sensory guided behavior is something that is just ubiquitous. Whenever we hear a sound, it is normally associated with some kind of behavioral output. And I always like to use this example of a fish show. This is a particularly exciting sensory environment. If the guitarist on stage here breaks into an amazing guitar riff, you're likely going to turn your head and focus your attention on him as he's playing. This is what I would call a sensory motor transformation, where you hear a sound and that drives a subsequent motor action. If they break into a sad song, that might elicit an emotional response. So that's a case where you hear a sound and it elicits some kind of emotional behavior. And these kind of sensory guided behaviors, we experience them in our day-to-day lives all the time. So if you're driving along the highway on your way into work in the morning and you hear a police car coming up behind you, there's going to be a series of different behavioral outcomes associated with that sensory information that is hitting your ears. There are going to be decision-making processes as to whether or not you want to pull over or whether or not you want to floor it. There's the actual act of taking that sensory information and guiding the act of pulling over with your car, as well as all of the emotional consequences. But the reason that I mention this is because what we think of as neuroscientists as the auditory system is a hub of audition. It's a hub of auditory processing. It isn't natively a hub of motor action or emotion or any of these exciting behavioral outcomes that are linked to sensory input. And so that's really what I mean when I make statements like sensory guided behavior is necessarily a brain-wide endeavor. If we want to understand how we use sensory information to interact with the world around us, we really need to understand how sensory information is propagated throughout the entire brain. We really need to consider not individual brain areas in isolation, but how everything is connected. So this is just a simple schematic of the ascending auditory system. Sound is transduced at the level of the cochlea, and it then jumps through multiple synapses in areas known as the brainstem, the midbrain, the thalamus, before finally it reaches this guy up at the top called the primary auditory cortex, which is a major hub in the brain of auditory processing. And what's really remarkable is that neurons in some of these low-level areas that are close to the cochlea, these neurons are really equipped with biophysical synaptic specializations that can support an incredibly high fidelity encoding of incoming sound. So on the right-hand side here, I'm just emphasizing this. On the top right, you can see this is a sinusoid. This is a sine wave, which is an auditory stimulus. This is a tone of a particular frequency. And what we're doing is just modulating the amplitude. So this is a sound that consists of a single frequency, and the loudness of that sound is varying as a function of time. And the main take home here is that if we look at the discharge patterns of a neuron in the auditory nerve, which is right next to the cochlea, you can see that the neuron is firing very, very reliably to the fine structure of this sound. If we then jump a few synapses and head up to an area called the midbrain, we can see that there's still quite reliable firing patterns, but especially at high frequencies, it's a little bit more degraded. And if we then jump another couple of synapses up to the level of the auditory cortex, it all becomes a little bit of a mess. And here I'm just plotting frequency as a function of time. And the main take home is that these neurons are not temporally precise. They are not actually representing the source signal. They're not representing incoming sound in a very, very faithful way. So I would refer to these as more rate-based abstractions. And one of the main reasons for this is simply modulation. Neurons, as you move away from either the cochlea in the ear or the retina in the eye, neurons become more and more subject to modulation. So neurons can talk to other neurons and change the way in which they respond to incoming sensory stimuli. And just as a slight side note, modulation is something that philosophers have been kind of thinking about and talking about for a long time. And I just kind of want to highlight a couple of really, really nice little quotes here. The first from Aristotle: persons do not perceive what is brought before their eyes if they are at the time deep in thought or in a fright or listening to some loud noise. This is a really nice quote that highlights the ability of other sensory modalities to modulate a sensory percept. Jumping slightly forward in time to Descartes, the soul can prevent itself from hearing a slight noise or feeling a slight pain by attending very closely to some other thing. And this is something that is very near and dear to my heart, because this is really emphasizing the fact that cognitive factors, so things like attention and arousal, are actually capable of modulating the way in which we perceive the sensory environment. So if you attend really, really hard to something in the distance, it can change the way that you actually represent incoming sounds. And as even more of a slight divergence, I want you to focus on this lovely little video of a cat, and pay close attention to the cat's pupils. Someone is blowing bubbles in front of this cat. At the start of the video, the pupils were very, very small and constricted. But as the bubbles appear, I hope you can appreciate that the pupil diameter here is actually changing as the cat directs his focus to the bubbles around him. And I'm showing this for a particular purpose, and that's because from a biological perspective, pupil diameter is actually a direct readout of different neuromodulatory systems within the brain. It's directly related to what some people refer to as the arousal state of the animal or the behavioral state of the animal, and it correlates with a lot of different behavioral attributes. For example, if your pupil diameter, if you're tired, if you're drowsy, if you're in a very low arousal state, your pupils are very small and constricted. If you're running to catch a bus and you're super, super hyper aroused, your pupils are absolutely massive. And there's a biological underpinning to all of this. And it's directly related to what I would call cognitive load and the kinds of input that the animals are receiving. And just to kind of emphasize that this kind of modulation we can see on a neuron specific level, This is an example of how pupil diameter can actually reflect changes in neural responses at the level of the auditory cortex. So in this particular example, we can see that pupil diameter is fluctuating across this recording session. So here we're just using an electrode to record the electrical activity of a particular neuron. Each of the gray bars indicates the time at which a sound was presented to this particular animal. And the black traces indicate the firing pattern of this individual cortical neuron. And the key point I want to convey here is that as the pupil starts to increase at points 2, 3, 4, and 5, in the blue region, the firing rate of the neuron increases also. So this is essentially telling us that the behavioral state of the animal has the ability to alter the way in which neurons fire and the way in which stimuli are represented throughout the brain. So your arousal state changes the way that sound is represented in multiple areas of the brain. So now I kind of want to move base slightly and talk about what I would call descending systems. So I've shown you that neurons can be modulated by the behavioral state of the animal, but what makes this particularly interesting and how this ties really nicely into this idea of sensory guided behavior is that the auditory system does not act as a single monolithic entity. It does not act in a vacuum. Cortical neurons communicate and transmit sensory information to a whole host of different brain areas. And this is typically known as the descending auditory system. So what goes up must come down. And although it's true that some of these brain areas are auditory, so there's a lot of reciprocal connectivity within the auditory system, a lot of them are not. So there are direct connections between the auditory system and limbic structures in the brain, like the amygdala. So the amygdala is a major hub of emotional processing. There are major connections between the auditory system and an area known as the basal ganglia. And one of the main targets within the basal ganglia is an area called the striatum. And the basal ganglia is heavily involved in motor action and initiating and suppressing movement. So connectivity with the basal ganglia puts the brain in a situation where it can actually take sensory information and convert that sensory information into a motor action. So connectivity really is everything. And as you might imagine, this can also have direct translational importance, right? So we're now in a situation where auditory responses in the cortex, they can be modulated by behavioral state, and this modulated information can be relayed to key parts of the brain that are able to regulate emotion. So if you suffer from an auditory ailment, so something like tinnitus or hyperacusis, anything that can directly affect cells within the auditory system, then it can also directly relate to emotional symptoms. So connectivity within the brain can directly translate to emotional variability in tinnitus sufferers and hyperacusis sufferers, etc. So what makes this a particularly exciting problem for neuroscientists like me is that we live in a very special time where we now have the tools and technologies to directly monitor and manipulate hundreds of thousands of neurons at a time in awake behaving animals. So we can really, from a basic science perspective, we can really start to dig deep and understand exactly how these circuits function for subsequent therapeutic benefit. So on the right here, I'm showing you some data recorded from my lab. We're shifting gears here to a microscopy technique known as 2-photon calcium imaging. So this is a technique where we use a cranial window preparation. So this involves replacing the skull of an animal with glass and treating this as a window to the brain. We use lasers to shine through this window and image and monitor large populations of neural activity. So on the right-hand side here, you're seeing a 3x3 millimeter window of neural activity. This is the entirety of the auditory cortex. So whenever you hear a sound, this is what your auditory cortex is doing. We can also use videography, high-speed videography, to actually look at what the animal is doing with respect to behavioral state when we're making these kind of recordings. We can use statistical techniques to actually track the pupil diameter as it constricts and dilates in real time. And we can use even more complicated technologies to activate neurons. There are tools and techniques that we can use where we can use light to modulate the activity of neurons. So in the previous video, I was showing a large population of neurons that were responding to sound. Here in this video, I'm actually using laser light over 3 different patterns or 3 different small populations, subpopulations of neurons, and I'm turning them on. So we live in this amazing era where we can really monitor and manipulate neurons in real time in head-fixed animals. And I'm just going to finish by running through how some of these technologies play out in a laboratory setting. So these are the kind of day-to-day experiments that my lab is actively engaged in to try and understand the neural basis of some of these sensory guided behaviors. So we spend a lot of time getting animals engaged in choice behaviors. And this is one of these such choice behaviors I'm illustrating here. So this is a head-fixed mouse. And we're going to get the animal to discriminate between 2 different auditory stimuli. And these are stimuli that are either fast or slow. And these are noisy stimuli, and all we're doing is changing their amplitudes. So it's either something that sounds a little bit like or and the animal has to tell us whether the stimulus was fast or slow by licking one of two spouts. And animals can be trained to perform these kind of tasks. So we can see that on the top right here, the animal's performance grows as a function of time. And on the bottom right-hand side, I'm showing something known as psychometric curves. So there are certain stimuli here that are harder for the animal to make decisions based on than others. So you can imagine the y-axis there as being task difficulty. And as task difficulty increases, the animal gets better at making the corresponding choice. And this curve shifts as a function of learning. So as animals get trained on this task, they get better and better and better at being able to make these auditory decisions. And one of the main take-homes that I want you to remember is that as animals get better at this task, so as they become more and more capable of using these stimuli to guide behavior, the representation in the brain of these behaviorally relevant sounds changes. So what I'm showing here is actually 4 different neurons that respond in different ways. On the y-axis, I'm just illustrating time from sound onset, and on the y-axis, I'm organizing things in terms of the stimuli that were presented. All of the blue stimuli are the low stimuli, or the fast stimuli, or the slow stimuli. The red stimuli are the fast stimuli. And the main take home here is that in a trained animal, we can actually find neurons that respond preferentially to either slow stimuli or fast stimuli. And we can quantify this in a number of different ways. This is just a simple little mathematical ratio where a positive number tells you that it's a neuron that likes low stimuli. If it's a negative number, it's a neuron that likes high stimuli. But the main point here is that this changes as a function of learning. So what I'm showing here is 3 different stages throughout the learning process: early in learning, in the middle of learning, late in learning. And this distribution of these numbers becomes increasingly bimodal, which tells us that these neurons that I showed you that can represent these behaviorally relevant stimuli, this changes as the animal gets better at the task. On the bottom, I'm showing you a situation where we're playing the exact same stimuli to the exact same neurons, to the exact same animals, but outside of the context of the behavior. So this is what I would call a passive listening experiment, where we play the exact same stimuli, but the animal is not tasked with actually making a decision based on these stimuli. And the effect completely goes away. So this is something very, very specific to do with when the animal is engaged in the task, when they are actually attending to the presence of the stimuli, the cortical responses are completely changing. And this heavily correlates with the ability to perform the task. So here I'm just plotting this index I showed you as a function of success rate in the task. So as these neurons become more tuned, more representative of these slow or fast stimuli, the success rate, the ability to perform the task increases. And just again, to emphasize this point, we can actually see that as a function of learning, these neurons are actively shifting their tuning properties to represent these different stimuli that are involved in the task. So I'm just going to finish with one slide just to kind of drive home the point that these biological problems really do have direct clinical relevance. There are a multitude of different disorders of perception. So from things like tinnitus and schizophrenia, both of these involve the perception of sounds that don't exist, to things like ADHD, so attention deficit hyperactivity disorder, that involves the irrepressible awareness of unwanted or distracting sounds. And the key message that I want to convey is that we only hear what the brain tells us to hear. And I think this raises a lot of really, really important translational opportunities, because the kind of basic science that I've described here really tells us about how neural circuits in the brain are organized and how they function. And this is critical information if we want to understand what happens when these circuits break. So I want to drive that home very, very clearly, that things like tinnitus and hyperacusis, a lot of these auditory disorders are brain disorders. And when circuits break, when circuits do not function in their correct way, it can lead to a whole load of different disorders of perception. And I think that this kind of research can really lead to insights as to what are the correct neural circuits to target for subsequent therapeutic benefit, as well as providing a kind of means to guide plasticity by being able to reinforce healthy patterns of activity. So I will end there by just acknowledging my lab, the people that did the work, and my support. And thank you very much for listening. And I'm happy to answer any questions you have.
Thank you both very much for taking the time to present. We do have several questions already. Again, if you'd like to submit a question for either Dr. Perez or Dr. Williamson, please go ahead and submit it through the Q&A function at the bottom of your Zoom screen, but we'll kind of dive into those questions right away. Dr. Perez, can you talk about how an implant works to assist deaf patients to produce speech?
So, it's interesting. Somebody who is born deaf and past the critical periods, Dr. Williamson talked about the plasticity and the ability of the brain to adapt. We know there are periods of time when you've been so long without the input of signals that the brain is used to organize these upstream circuits and representations of meaningful sounds that we don't anticipate somebody to develop normal speech. So somebody who was born deaf and couldn't even use a hearing aid to help with their hearing, after a certain period of time, really can gain sound awareness, but it's just close to 0% chance that they would ever obtain normal speech understanding. Now, many patients are born with severe hearing loss that is amenable to hearing aids, and they might progress over time, have worsening hearing loss to the point where they might become a candidate for a cochlear implant. And specifically in answering the question about speech, is that an important part of how we speak involves our ability to understand, to hear our own speech, and to make modifications in that. So you can see patients who developed normal speech, but then subsequently lost their hearing, can have some improvements in their speech and their ability to understand speech with a cochlear implant.
I'm going to kind of roll the next two questions into one. So you talked about expanding cochlear implant treatment across Western PA. Is cochlear implants and updates in that technology, is that something that pediatricians and PCPs are, kind of tapped into and get those updates regularly? And if you're talking to somebody from rural Pennsylvania, what would you kind of tell them as a first step if they're interested in cochlear implants, if they're hearing loss?
Well, fortunately, it's the state of Pennsylvania, and really all states have some regulations, but we have what are called newborn hearing screenings, where the hearing will be tested at different intervals with the goal of very, very early on identifying babies who have hearing loss that are amenable to treatment. So knowing who has what level of hearing loss as early as possible to know all the options. And does that mean that a hearing aid is provided early on, or a child is born really with no hearing and they're early on the track to consider the option of a cochlear implantation? Part of this process involves a lot of clinical testing with our audiologists. So standard hearing tests you might get when you walk in the door of most audiologists is kind of a screening tool to help understand, might the hearing loss be so significant that you start going through more testing to show that you really have such poor hearing that you're a candidate for a cochlear implant. So what's frustrating on the patient side is to go through that process and end up having to make multiple trips driving a long ways to a center to have testing set up for 2 months down the line. So part of our streamlining process that we're working on is with our satellite locations, identifying who is likely to be a candidate for a cochlear implant. And that can be done with really kind of a screening audiogram that will give us a good sense of whether you would consider that and start going down the more lengthy testing for that process. And if that's the case, we get you plugged in to an appointment where you see the audiologist for about a 2-hour testing session. And that same day, then come meet with either me or Dr. McCall to discuss the results of that testing and the kind of practical aspects of the surgery and the process of rehabilitating hearing with the cochlear implant. So that's kind of a long answer, but we would love to plug you in with a local audiologist, and then with that screening audiogram, get you plugged in to see might you be a candidate for cochlear implant candidacy testing.
How do you deal with resistance from the deaf community to cochlear implants? Is that something that you've experienced?
So that's something I didn't touch on at all, but early on when cochlear implants were being developed, this was really perceived by some in the deaf community as the ethnocide or genocide, to say that the deaf community does not deserve to exist in their current state, and that this is a disability that must be treated with cochlear implant. Over time, there's definitely been a shift in some of those views in the deaf community. It becomes a tough choice, because most children who are born deaf are born to normal hearing parents. And those parents are forced with a tough decision wherein they have to decide to proceed with a cochlear implant at a certain time point, or really miss out on that critical period and the opportunities to develop normal speech understanding. And so it's a decision that has to be made by caretakers. It can't be made by a 6-month-old about their future. But I would say that there's been a greater reconciliation for many patients to say it's possible to have a cochlear implant and still participate in the deaf community, which is a rich community with its own benefits. And so it's not an easy decision for some people faced with these tough questions. And it really becomes more germane, I would say, for children because of that critical period of time where if you receive a cochlear implant, you can go to a regular school with normal hearing children and kind of track along what we would call a mainstream pathway. But it's a discussion, and it's everyone has to come together to really talk about all those issues.
If an older person, for example, age 70 or so, gets a cochlear implant after having hearing their whole life, are their brains able to quickly adapt to hearing in this new way, or do they still need a lot of rehab?
Well, it depends a little bit on what they were hearing before surgery. So somebody who was wearing hearing aids and stimulating all those pathways upstream that Dr. Williamson spoke about still has tight connections where we see that you stimulate that hearing nerve, and there are a lot of upstream connections that are tight and receptive to that information to develop normal speech understanding or improved speech understanding. But everyone is different on the pathway of that plasticity and how quickly they return the ability to improve and understand speech. So young children who are implanted early do extremely well. Older adults who have still been using hearing aids and still been receiving auditory information and have some speech understanding with hearing aids also tend to do well. It's the folks who have had no hearing for many, many years where we think some of those connections have weakened and they have a lower chance of successfully rehabilitating speech understanding.
Dr. Williamson, what research targets is your lab working toward at the present moment? If there's any kind of tangible goals that you have.
Yeah, I mean, there's a few different things that we're working on. My lab is very, we're kind of split down the middle with respect to what I call basic science and then more translational science. From a basic science standpoint, like I touched on in the talk, we're very interested in these ideas of sensory guided behaviors and trying to understand the neural circuits that give rise to them. So we spend a lot of time working out what circuits link the auditory system to the rest of the brain, so more anatomical studies. And then we do a lot more behavior and physiology to try and understand how these different circuits contribute in different ways to different kinds of behaviors. So things like decision-making behaviors or more complicated freely moving behaviors where we have animals navigate an open field and use sound to guide their judgments. From a translational standpoint, a lot of our work is driven by noise-induced hearing loss. So we'll use noise to affect the input that the auditory system receives. And whenever you do that, that then sets into motion this kind of war between excitation and inhibition. So neurons that fire too much or too little. And this is a major problem for things like tinnitus and hyperacusis. If you have auditory neurons, if you have sensory neurons that fire too much, you can interpret that as being some form of an auditory hallucination, essentially. Because you have a sensory neuron that is firing when it shouldn't, the brain can interpret that firing as being a representative of an auditory stimulus. So we perform a lot of experiments in that vein. So eliciting changes in excitation and inhibition with noise exposure, trying to then understand how this reduction in hearing affects the ability to perform behaviors. So things like how does it affect decision making, how does it affect our ability to dissociate tones in noisy environments, all this kind of stuff. And then the other aspect is I'm very interested in the interaction between hearing loss and Alzheimer's disease. So one of the kind of connections I didn't really touch on during the talk is that the auditory system is very connected to hippocampal circuitry in the brain, and hippocampal circuitry is critically involved in learning and memory, and it's also one of the first areas of the brain where plaques start to deposit in Alzheimer's disease. So we have some money from the NIH. I collaborate with some Alzheimer's researchers in neurobiology, where we're actively looking at cognitive decline in auditory tasks and trying to look at how connectivity between the auditory system and the hippocampus is affected in different mouse models of Alzheimer's disease.
So kind of a follow-up question to that, and I know that you're doing a lot of basic science, so this could be a difficult question, but you talked about issues such as tinnitus or ADHD or even schizophrenia. Anybody who follows the Eye and Ear Foundation knows that, Dr. Xenopoulos has been working toward a pharmacological cure for tinnitus for a long time and has been made really good progress in that area. Do you see an opportunity that perhaps in the future the research that you're doing could help, lead to a pharmacological treatment for those other conditions like schizophrenia and ADHD as well?
That is a hard question. So schizophrenia is a hard one because there's multiple different, there are clearly, the symptoms fall into different camps, right? So the kind of, when I say things like schizophrenia, I'm purely referring to the sensory symptoms. So the positive, negative symptoms, that's a different ballgame. But something that is fascinating to me is how flexible the brain is and how different neural circuits can, dependent on the context in which they become active, are involved in different things. So a lot of the circuitry that we now know to be involved in tinnitus and the propagation of neurons that fire unnecessarily after noise exposure, it's the same circuitry that people have been studying in schizophrenia for the last 30 years. So there's a lot of overlap there. And if there's overlap in the circuitry, then either through pharmacological means or other means to manipulate connectivity, there could be therapeutic benefit there. So the pharmacology that Dr. Xenopoulos works on is at the level of the cochlear nucleus, which is really, really close to the ear. What's remarkable is that as soon as something gets messed up early on in the pathway, everything propagates. In the same way that you can have cochlear implants, you can have midbrain implants, there are different levels at which you can target these kind of problems. So if you can't target it near the source using something like the pharmacological interventions you mentioned, then yes, maybe we can head up to the level of the cortex and start manipulating connectivity that way. I mean, the example I always like to give is Parkinson's disease, because Parkinson's disease, almost everything that we know about Parkinson's is through basic science research. We identified areas within the basal ganglia that we can target with things like deep brain stimulation to minimize a lot of the symptoms of Parkinson's. And my hope would be that by identifying some of these circuits and identifying critically how they're involved in these different auditory ailments, we can manipulate them in real populations.
Yeah, thank you for that. So we have a question here that maybe I'll expand upon just in case anybody online is not familiar with the Eye and Ear Foundation. The question says, does the Eye and Ear Foundation accept patients for eye and ear issues? So the Eye and Ear Foundation, we are a 501c3 nonprofit that we act as the fundraising arm to raise funds for research taking place for hearing or eye and ear issues at the Departments of Otolaryngology and Ophthalmology at Pitt. So we do not see patients. However, if you're interested in seeing Dr. Perez, for example, for the hearing treatment, for otology, yes, you can see patients, you can see people in the Department of Otolaryngology here at Pitt and UPMC, and also our doctors with the Department of Ophthalmology. And you can certainly reach out to them and get set up an appointment if you'd like to see somebody in those areas. So I guess I'll finish here with one last question, maybe for Dr. Perez. Does a cochlear implant work if there's brain damage? For example, if somebody's had multiple concussions, are there complications from that?
It's a good question. So Dr. Williamson has a nice slide that shows really early on the hearing information splits and goes to both sides of the brain. So it's rare that you have an injury that really would preclude use of a cochlear implant, except when we think about things like damage to the hearing nerve itself. So there's some surgeries, some tumors that grow right on the hearing nerve that then limit our ability to stimulate that nerve and know that it's just not going to receive those signals and send them where we want. But Dr. Williamson actually also mentioned, there's research into implants higher up in the auditory system. And, for those specific issues like damage to the cochlear nerve from a tumor, there's still in kind of the research phase, but the option of something called an auditory brainstem implant that can bypass that. But something like a concussion that we think globally can affect the brain could limit some of the cognitive power you need to, really go through the intense rehabilitation to retrain the brain how to respond to these signals. But we see many patients who have some limitations of cognition that still do really well with cochlear implants. So less and less do we find reasons to say you definitely shouldn't consider a cochlear implantation. We see more and more success in a broader application.
Thank you. And again, if anybody has any other follow-up questions they'd like to send, feel free to email them to me. My email is craig@eyeandtheear.org, and I'd be happy to pass this along to Dr. Perez or Dr. Williamson. Thank you both again for participating today. We're going to take a slight break from our presentation for just a few weeks. Our next webinar will be on August 9th, where we'll be having a presentation on HPV and head and neck cancer epidemiology, which will be presented by Dr. Zavaios, who is the new chair of the Department of Otolaryngology as of last year. So that should be a great presentation, and we look forward to having some of you on board for that one as well. Dr. Perez and Dr. Williamson, thank you again, and we hope everybody has a great day.